Thank you, Borja. It's a great privilege for us as a task force to present in detail the STEMI Guidelines 2017. This is the general program. I'll give a welcome and general overview, followed by dedicated presentations on the details of different chapters. Pascal Ranks, Sigrun Halvorsen, Eva Prescott, Stefan Agarwal, Hector Bueno, and finally Borja Ibanez will summarize the session. This is the document that you can download now from the ESC website, and all the task force members in names. These 19 task force members are representing the European Society of Cardiology, different associations, councils, and working groups, and many European countries, as you can see, symbolized in blue, under the surveillance of the ESC Guideline Committee and headquarters at the Heart House. The document has also been reviewed by 30 reviewers who have thoroughly gone through the documents and all the evidence behind it, and gave us more than 1,200 comments and requests in order to improve the quality and the integrity of these guidelines. We've gone through the literature thoroughly. We have formed 159 recommendations, and 92 recommendations we have classed as a class 1, which is something that there is evidence or general agreement that a given treatment or procedure is beneficial, useful, or effective, and something we consistently in the document word as something that we recommend, something that's indicated to do. So that's a strong recommendation. In bright blue, 38 recommendations are class 2. Weight of evidence is in favor of usefulness or efficacy, something that you should consider. And 13 are something that you may consider. The usefulness or efficacy is less well established by evidence or opinion. But we also want to give you 16 recommendations that there is evidence that the procedure are not useful or may be harmful. So we recommend against that particular therapy. When we went through the literature, we have added 477 references to the document, and we have graded the evidence, and so that 37 of the recommendations are labeled as A, which is defined as data derived from multiple randomized clinical trials or meta-analyses. 44 of the recommendations are classified as level of evidence B, meaning that the data are derived from a single randomized clinical trial or large non-randomized studies. 78 of the recommendations are based on consensus of opinion by the experts. You should be a little bit more careful about these. Still, we think it's important in many instances to give recommendations, although there is insufficient evidence in the literature. So there is an enormous need for further research for the future to establish better evidence. We have, in creating these guidelines, we have been evidence-based. We're basing it on solid evidence, but still we want to make them user-friendly. So we have introduced a number of tables, figures, and flowcharts in order for you and for us as clinicians to use these easily, to have an answer to most of the questions you are facing when you are seeing patients. We have indicated by these different tables and figures and flowcharts changes in recommendation. This particular table shows changes from the 2012 version. And you can see that we have updated some, we have downgraded some recommendations, and we will go through this session over these different recommendations in detail. You can see that we have upgraded radial access, drug-eluting stents versus bare metal stents, complete revascularization during the initial hospitalization, downgraded thrombus aspiration, downgraded slightly bivalirudin, upgraded enoxaparin, and upgraded early hospital discharge. We have changed the level of oxygen from 95% to 90% to avoid treating patients with oxygen who are not hypoxic. And we've changed some recommendations in detail with respect to thrombolytics in elderly patients. We've also introduced a number of new recommendations, completely new recommendations, related to additional lipid-lowering therapy in patients who do not meet the initial lipid-lowering cutoff levels. We've also introduced an ability to use cangrelor in the cath lab for patients with ST elevation myocardial infarction undergoing PCI. Also, switching of P2I12 has given some attention, extended duration of ticagrelor beyond 12 months, and the use of polypill. We're also recommending against the use of routine deferred stenting according to the DYNAMO-3 deferred study. These are the new concepts or considerably revised concepts that we've introduced in the guidelines. And those are important. We've introduced a new chapter on MINOCA, which is patients who present as possible ST elevation myocardial infarction but have non-obstructive coronary arteries. And we give tips how to further evaluate and treat those patients. We also have a new chapter on quality indicators. We think it's important to start to measure, to be able to compare procedures and outcomes between institutions and countries. So we have a full chapter dedicated to the quality indicators. We have changed the concepts around strategy selection and time delays. We have clearly said that this clock starts at the time of STEMI diagnosis. And we have eliminated all ambiguous terms such as balloons and doors to balloon, door to door, etc. And we've also reclassified the limits for routine opening of the infarct-related artery. So PCI is more often recommended, but in some instances, beyond if there's more than 48 hours since the presentation, we don't recommend routine PCI in addition to angiography. We have revised the concept of the electrocardiogram being more inclusive in these recommendations. We not only recommend patients with ST elevation being brought to the cath lab, but also we recommend patients with bundle branch block, those with left or right, whether they're old or new. And also those with atypical EKG presentations, we recommend for a diagnostic angiography. We have changed the time to angiography after fibrinolysis, and we have new concepts on patients who are on anticoagulation. So with that introduction, I give the word to the next